Hello, I'm Dr. David Johnson, Professor of Medicine and Chief of Gastroenterology at Eastern Virginia Medical School in Norfolk, Virginia. Well, COVID-19 is a continued world pandemic, and we have a lot of complicated patients, inflammatory bowel disease patients in particular, on a variety of immunosuppressants and biologic suppressant type medications, which potentially complicate the immune system. And what do we do with these people when we talk about COVID-19? Well, kudos for an amazing, heroic effort by the International Organization of the Study of Inflammatory Bowel Disease group. This is a group of approximately 80 physicians around the world, 26 countries. They were scheduled to meet in mid-March, and they postponed their meeting because of the COVID epidemic. And certainly they then rapidly convened a task force to put together a Delphi-type consensus over a series of statements. And they looked at 76 statements, and then in a modified Delphi, within 2 weeks, were able to return and revise these statements. Ultimately, they had a total of 76 statements. They rated 26 as appropriate, 19 were uncertain, and 31 were inappropriate. So what I wanted to do was give you the highlighted guidance as far as what this expert group put together. Well, the group, for one, said that the good news was in patients with inflammatory bowel disease were not thought to be of increased risk as it relates to SARS-CoV-2 or COVID-19. That's important because of the recognition that the target cell of entry is the angiotensin converting enzyme type 2 cell, and this is something that we know is in the upper and the respiratory tract, but also in the GI tract, particularly the small intestine and large intestine. So they said it was not of increased concern in the IBD patients. The group was also subject to the idea that postponing any elective procedures made sense. That's intuitive. We're doing that generally across the board. But then they looked at a couple of things. If the patient actually is a COVID positive infected patient, delaying and the inflammatory bowel medications are held, to withhold those for 2 weeks until the resolution of symptoms and then restart appropriately at that point. And that's kind of what we do with infections as a general rule anyway. As it relates to medical therapy, here's where the meat on the bone, I think, is really important. If they're on steroids, they recommended reducing the steroids or withdrawing them to prevent the risk for the SARS type of coronavirus infection. So that would be something in a proactive way in patients on steroids. If they're on a combination therapy with a biologic and an immunosuppressant, it was not really clear. It was mixed whether or not they should remove or reduce the immunosuppressant co-therapy. But certainly if they became infected, then that would be removed and continue the biologics if they could. As it relates to the patients that are on protocols, and we have a number of those across the innumerable studies that are out there, the group suggested that it was still appropriate to stay in the protocol provided they weren't COVID positive. And certainly that would be if COVID positive. It was mixed as far as what the response would be, but the recommendation was to stop the investigational medication at that time. I think the key message here also is about infusions or injections, and the bottom line was continue at an infusion center, obviously, that has the COVID protection and prerequisites for screening. And then for the injections, which are done at home, obviously the recommendation was to continue medication. So why would this make sense? We do know that the biologic half-lives of the inflammatory bowel medications we generally use, it takes about 5.5 half-lives to clear the system, or at least to get to low-level detectable. And that occurs for a variety of different drugs in different ranges. Corticosteroids is approximately 24 hours. The thiopurines, about 7 days. Methotrexate, very rapid at 6 hours, and even more so, tofacitinib, 3 to 6 hours. So again, very rapid clearance in this particular drug. When you start to look at the more injectable and infusion type medications like adalimumab, it's 10 to 20 days, infliximab is 7 to 12 days, ustekinumab is approximately 19 days, and vedolizumab is 25 days. So what does this mean? Well, 5.5 times those numbers of days gives a long extended exposure, at least. So stopping the medication doesn't necessarily change your immune response in any very short period of time. But let's take it a step further. Looking at the effects of COVID-19, the patients that seemingly do the worst have this cytotoxic putative storm. So there's a hyper-accelerated response, in particular for the COVID-19 virus, not necessarily dependent on the viral titer, but the presence of the virus. And this cytotoxic response results in a variety of upregulations of white cell activation and migration factors, very much upregulating gamma interferon, interleukins, in particular interleukin 6, some interleukin 2, and anti-tumor necrosis factor alpha. Now, why is that important? Well, think about what we just said. Those are targets, aren't they, for a lot of the inflammatory bowel type disease mitigation strategies with biologic and immunosuppressant therapies. So there may be some benefit, conceivably, of medications that these patients may have. So what do we do? Well, we can reassure our patients that they're to continue their medications, reassure that they should stay the present course, obviously with COVID precautions. But nonetheless, kudos to this incredible group of leaders, and that's what leaders really do in time of crisis. They lead. And this international group gives us excellent guidance, reassurance, and justification for management of a very complex group of patients on biologics and immunosuppressive therapies. Again, our thanks to them, and hopefully this will provide you good information in your future decisions and current discussions with your patients. I'm Dr. David Johnson. Thanks again for listening.